Okay. Getting there. There we go. Good. Okay, well, we got some people straggling in, but what we need to get going to stick on time. Welcome back to OSU's Research Day, and I'm now pleased to introduce Ms. Maureen Smith and Drs. Rob Reid and Carrie Kolusky, who will be providing us with an update on the progress towards a learning health system. Maureen Smith, various hats and roles. She's currently a member of the OSU Board of Directors and serves a number of vital roles in the support unit. Dr. Robert Reid is inaugural Hazel McCallion Research Chair in Learning Health Systems and Chief Scientist at the Institute for Better Health and Senior Vice President of Science at Trillium Health Partners. And Dr. Carrie Kolusky is the Dr. Matthias Giesler Research Chair in Patient and Family-Centered Care at the Institute for Better Health at Trillium Health Partners and Associate Professor at the Institute of Health Policy, Management, and Evaluation at the University of Toronto. I'll turn it over to Maureen to take it away.
Bring this down. Hi, everyone. Bonjour tout le monde. Nice to see so many familiar faces, and welcome to everyone who's online. Thank you, Dean. So I'm accompanied by Drs. Rob Reid and Carrie Kolusky on Zoom today from Mississauga. Unfortunately, Carrie and Rob couldn't be with us in person today, so we're doing this hybrid through the magic of technology. As you might recall, we presented last year with John Lavis on the concept of the learning health system and our early work. And promoting a patient-centered learning health system is a priority of OSSU and its recent renewal. So today, we are presenting an update 1 year later on the progress to date done in collaboration with the Learning Health System OSU Working Group. I also want to call out Dr. Nakia Lee-Foon, sitting with Rob and Carrie today. She has been instrumental in getting us to this stage. So thank you, Nakia, and all the work group members. We're terrifically excited, that's coming from Rob, to announce the OSU debut of the Learning Health Systems Action Framework. You researchers try to contain your enthusiasm. I know how you love frameworks. So a made in Ontario learning health system model for all of us to use. We have also advanced our work on understanding the role and place of patients and communities in the learning health system. And it's wonderful to be in the presence, in person and virtually, of our patient partners today, many of whom helped us with this work. So we're going to present today as a tag team. Rob's going to lead off and present the Learning Health Systems Framework for you. In a written brief on the framework will be available shortly on the OSSU website, and you'll all be told when that pops up. And after Rob, I'll talk a little bit about the work of the patient, family, and community engagement as part of the learning health system. And Carrie is going to round out with an example to bring it from the 30,000-foot level to real-life application. So, and then we'll open up for questions. So without further ado, Rob with the framework. So Rob, I'm going to advance the slides. So if you can just say next slide, I can do that. Okay. And are we going to have them on the screen? Can we see them? Oh, they're there. Oh, hi. I don't see them over there. Okay, so I'm going to advance. There we go.
Okay, thank you, Maureen. And nice to see everybody. We apologize for not being there in person. It's a big week for healthcare in Mississauga, so we're here, but we're with you in spirit in Toronto. Before I start, I really just wanted to call out Maureen. Maureen, you have been the best partner in this work as a patient partner. You've absolutely embedded the patient voice, the community voice throughout all of the work. And we couldn't have asked for a better partner than you. So really congratulations to you. Thank you for being there in person. And it's a very special day for Maureen today. I just wanted to tell everybody it's Maureen's birthday today. And it's a very, very special birthday. So on behalf of OSU and all of us, happy birthday, Maureen. We wish you all the best, and thank you for taking some time on your very special day for joining us today at OSU. I will go through very quickly because we actually really need to hear from Maureen. So I'm Tad back, and I'm going to introduce the framework that we've all been working on that now it's getting its almost TIFF debut today for all of you. You'll get a brief shortly. There's a peer-reviewed manuscript in the works, videos and so forth, so you can all use this framework. Just a few slides to ground us in last year's discussion, just to make sure everybody knows what we're talking about. This is the Canadian definition for learning health systems from 2018. And thank you, John Labus. This has now been pretty well adopted Canada-wide. And just remember that this is about timely data and evidence. It's about anchoring it in citizens' needs, perspectives, and aspirations. And it's embedded right within the system, with decision supports, governance, financial, and care delivery arrangements. And most of all, it's about culture and competencies for rapid learning and improvement. So that's where we start. Let's go to the next slide. Just to frame people, to recall this slide from last year as well, is that learning health systems is a natural evolution from our traditional thinking around the brokering function of knowledge translation and exchange, where learning health systems now are embedded directly in systems, directly working with patients, providers, and system leaders in day-to-day care. So it's no longer removed. It is central to the operations of health systems. Next slide. This is also a very important slide that also we presented last year in a little bit of a different form, and with some patient perspectives built in now. We have shifted our visuals on here, but just remember that learning health systems it has layers. We talk about layers of learning units. At the base level is always patients and clinicians. So this is the idea is can we deliver the best evidence to patients today from what was actually derived from their experiences from yesterday. So can we serve up to patients and clinicians immediate high quality evidence in a very rapid cycle? So that is at the base level. Clearly, we need to learn at other levels as well. We need to organize, we need to finance, deliver care in new ways in healthcare teams, organizations, and local systems. And I just wanted to just stop on local systems because this is where there's a bit of confusion often. When we talk about learning health systems, we're talking about systems that are cross-sectoral, patient-centered, integrated, population-based, and really proactive in nature. And then finally, we need learning at the more senior levels. And I was so glad to see the deputy endorse the perspectives this morning. And we need the regulations, the funding arrangements, and the overall frameworks at the provincial level to make everything articulate. So learning is required at all these levels. The next slide. Okay. This is a key slide as well. You saw last year. I just wanted to reemphasize it. This is a slide from Maureen. Often we talk about learning systems as a real partnership between healthcare delivery and health, even social service delivery more broadly with research. But clearly patients, citizens, and caregivers are at the center of here. Maureen talks about this as the wobbly stool, that we give not enough support to patients, caregivers, and citizens around lifting their voices in the learning activities that we have. And we'll talk, Maureen, a little bit more about that and how we lift the participation of patients' systems. Okay, drum roll. Here's the framework that all of you helped articulate this year with us. This is, and thank you so much to all the patient partners and all the collaborators at OSU for helping us articulate this framework. And you'll see that the framework is presented as a learning engine. And of course, it's a clean engine that actually creates motion in a production line. And many of you might be wondering why it's articulated as an engine. because that's actually some of the feedback we got directly from patients and community members, because this is something that they could understand and grasp onto. So it's presented as an engine. And of course, it has a variety of learning gears, and we'll talk about that in the middle of it, that make it function. And it has a production cycle in terms of producing the quadruple aim. You can see that on the right-hand side. And equity. And equity is considered as a central aim. It is not its own thing. It is a pervasive aim across everything. And so it's equity in experience, equity in outcomes, equity in workforce, and equity in affordability. And then all of the equity, all of the other gears need to embed equity within their perspectives. And as you can imagine, an engine doesn't run on its own. It needs a variety of fuels and accelerants. And so that's the top box. It talks about what needs to happen to make this engine operate. Because it needs constant infusion. These gears don't push by themselves. And in that, you can see that we have a lot of, the top row is about engagement with patients, families, providers, community, equity, Indigenous and equity deserving groups, and of course, the health workforce. It needs leadership at all levels to work and function at health systems levels, research and patient levels. And then at the base, it needs scientific expertise. And thank goodness we have that in spades in Ontario. Funding, data technology, information, and learning networks. And then finally, there's a variety of moderators and breaks. Some people say these as barriers. We don't view them as barriers. We view them as things that keep us on track, give us direction, and make sure that things are done ethically. So this includes our capacity for change, our priorities for change. Clearly, we have to deal with laws, regulations, and privacy concerns. And then ethics, governance, and accountability is core. So that's the intakes, accelerants, and moderators. Let me just go in briefly to the gears. Let's next slide. And these gears are now where different types of evidence comes together in a learning cycle. And you'll see, all of you will see yourself in different gears here. Our view is that they're interarticulated. The evidence types work together in sequence and together to produce learnings. The first one, we've talked a lot about this morning already. It's about advanced data and analytics. And the use of advanced analytic data analytics platforms to do that. But don't forget that it's also about patient and family and community views, perspectives, and aspirations. And so qualitative methods are exceptionally important in the data inflows. The second gear there is all about what's known outside our environment. And this is evidence synthesis in its many different forms. I won't go through them today. It's articulated in our brief, but it's really bringing together what's known outside, contextualizing it for learning internally to Ontario, into our local systems. And at the center of these now is the patient, caregiver, and provider co-design. And it's about using those two forms of evidence, both internally through data, understanding the nature of our problems, and then bringing what's known externally into the funnel to patient, caregiver, and provider co-design. Really engaging with advanced methods around how to do this, and particularly how to lift in those design activities the voices of equity deserving groups that are often too missed. The fourth gear is all about implementation. You can design the best systems in the world with patient and provider co-design, but unless we implement it effectively so it reaches the populations we intended to do, it's not effectual. And so it's about implementation really quickly. And that's all about behavior change in many respects. And it's about change management. So it's about implementation science. And then finally, it's about realist evaluation techniques, about bringing data rapidly to understanding how things are working, what's not, what is working, and rapidly changing this. So those are the learning frameworks. There's a lot more detail in the brief that will become. We've got a video coming out as well that gives more detail and hopefully we'll have a peer-reviewed manuscript for you soon. I'm going to hand it back to you, Maureen.
Okay, so just checking, is there like an eject button on the stage? Because our time's running out. Am I going to get like, these guys are going to go into virtual reality, but am I going to be ejected? So can we have, because I'm going to go through quickly, but we're running out of time. So, okay, all right, just making sure. So thanks, Rob. So just very shortly on the patient perspective. So again, is it the newest buzzword? That's a big concern for patients. What does it mean in practice? How we move beyond the three-legged wobbly stool? What does it mean for patient outcomes and care? Who rotates those gears? And how can we be part of the system? Those are a smattering of the questions that I've heard from patients, caregivers, and community members about the learning health system. So I put the definition up at the very top, and the point of this slide is that we're more than just data donors. When we think of the learning health system, we think a lot about data, but we are more than just data donors as part of the learning health system. So the scoping review that I think it's Nikia who led it, found very few articles discussing the level of patient involvement, and there wasn't very much. There's no common language, there's no tools. Oh, now there's a framework, that's good. But for discussing and operationalizing learning health systems and making it likely that many healthcare institutions are using the approach without explicitly naming it as such. So you may be part of a learning healthcare system, you may have participated, and you might not even know. And I think that's a real gap. And that there are tools that exist for engaging people, and Carrie will talk about one of those, and communities with diverse voices and needs, but we're not sharing that enough. So there's a lot of roles here, and always a challenge and opportunity. So there's a big role for patient-centered research, but the CIHR grant system makes it a bit difficult. It's not really suited to building that sustainable engagement capacity once the funding is used. Now, we have the Empower Awards. That's a really good step in that direction, because you can continue your work. But so often we don't see the impact of our efforts. So especially when we're talking about diverse communities, we talk about building relationships, but everything is built on the grant, and once the grant ends, we just say goodbye to everyone. So there's work to be done there. We have these wonderful patient and family advisory councils who work in Ontario so hard, but we're siloed between the people who do the patient-partnered research, and there's this wonderful opportunity to bring those two, together, both equally valued as partners in the learning health system, because they bring so much good, valued information also. And then the Ontario health teams are making strides, and there's some really good work being done. We need greater communication of those successes, and it's uneven at this point. So it really depends on where you are and what the capacity is. And I know they're working really hard on that. And of course, the institutional governance bodies can be tokenistic. That meaningful engagement requires training and hours for everyone involved, and it's change management, and that requires culture change, and we know that takes a long time. This is my last slide. So pathways to moving forward: communicate clearly to patients, caregivers, and communities how their feedback is used in the learning healthcare system, learning health system, and how that data collected is used to improve patient care with concrete examples of impact. Carrie's going to present on that. Determine whether your health system has the workforce, the capacity, the infrastructure. You can't just click your fingers and make it happen. To nurture that continuous work, and then make it a goal to support that engagement. Take a step and make it a goal. And then we need to learn from best practices, and there are a lot out there, just not always communicated. So I'm going to hand it back over to Carrie, who's going to give us a really good real-life example.
Great. Thank you so much, Maureen, and so nice to be here today. And just building on what Maureen said about people who use healthcare are more than data donors. And we often hear this when we've done interviews with patients and families and communities. When people choose to share their experience, they have shared immense frustration at sharing that experience and then not getting a response. And this is something that we grapple with all across the system, where we want to hear from people, but sometimes we don't know what to do with what we hear. And sometimes the data is not actionable. And so our team, led by Lauren Cadell, did a scoping review as we emphasize in learning health systems, looking at what evidence is out there. So we did a scoping review to see what are other health systems doing to better collect and action patient experience data. And we realized that across the globe, this is something that many health systems are struggling with. But as we engaged our communities and as we looked at the literature, we did see that there's 4 key things that really need to happen if we're truly going to understand people and use that information and work with them to improve care. And so one piece, and I'll run through these components very quickly, is to really optimize how we're engaging with our communities. We talked a lot about this in the morning panels. What do we mean by community? How do we reach them? And how can we work together so people feel comfortable to share what works for them and what doesn't work for them in the healthcare system? We have lots of data collection strategies that we currently use, like surveys. Are we optimizing the way that we ask questions? Are we getting valuable data? Are we getting actionable data? How are we sampling when we use those methods? Another piece is to look at all the different inputs we have for experience data, community engagement, surveys, providers are doing rounding with patients in the health system. So how do we bring all of those sources of data together to fully understand all the different pieces of experience that people have to help care teams make sense of the data? And then finally, how do you then loop that and bring it back to clinical teams to work with patients and families to co-design quality improvement initiatives? So all of the things I've talked about, we're currently exploring through one-on-one interviews and co-design sessions to understand, first at Trillium, how do you action each of these domains and a broader patient experience strategy? And a big shout out to Emily Cordeau, a PhD student who has led several interviews with leaders, managers, patients, community members to unpack this. We did a workshop at an international conference to present this framework, to hear from other health systems. Are they struggling with the same thing? Yes. And how do we start to put a strategy together? And patient and family partners were part of the dialogue within this session. And honing in on what we're hearing finally in the final slide, what are we hearing from patients and families? And you can advance to the next slide. They reminded us something we heard this morning. It's about the journey. We can't just collect this patient experience data at one point in time. We have to think about how we connect the dots across the entire patient journey. Also, the accountability mechanisms really need to be there. So how do we make sure that we action what we hear? And that's where the learning health system is fundamental. Having the right players plugged in so we learn how to understand the data and then action it and then implement improvements and continue to iterate and co-design together. So the journey is never really done, but we're constantly improving based on what we're hearing from our communities and patients. And also being really mindful, we heard from patients, families, and communities, there's many factors that shape how people want to share their experience, if at all, and what modes we should use to best engage with them, whether it's community tables, whether it's surveys, whether it's through focus groups. So there's lots of different ways, and we have to consider language barriers, different abilities and disabilities that people may have that will impact how they can share and voice their concerns. And so that's one concrete example that we're working on at Trillium and looking to expand that elsewhere across the system. But really, it's true partnership, not just with patients, families, and communities, but with researchers, with managers, healthcare leaders, people who work in data infrastructure to help to advance this. So I'll leave it at that, Maureen.